Hello, everyone, and welcome to today's webinar, Best Practices in Blood Gas and Clinical Chemistry Laboratory, Leveraging Automation and Instrumentation to Minimize Errors and Enhance Testing Accuracy. My name is Matt Thorne of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Radiometer. To learn more, visit radiometer.com. We do encourage you to participate today by submitting any questions you have during the presentation. To do so, you can simply type them into the Ask a Question box and click Submit. We'll try to answer as many questions as we have time at the end of the presentation. You can also use that Ask a Question box to let us know if you're having any technical issues hearing or seeing the presentation. I'd now like to welcome our speaker, Dr. Imir Metushi, Assistant Professor at UCLA. Dr. Metushi, you can begin your presentation.
Thank you, Matt, for that introduction, and hello, everyone. Happy to be here today on this Lab Week Day. First and foremost, these are my disclosures. And today, I want to talk a little bit about the landscape of clinical chemistry and its evolving landscape as we are constantly asked to grow and expand our business. I want to talk a little bit about things that we have done to kind of maintain that quality of tasting that we all strive for and identify maybe some areas of potential improvement. I want to talk a little bit about some common pre-analytical errors that occur that do come back to us and see how we can best focus to mitigate and optimize our processes for best performance in the future, and also go over some laboratory automation initiatives that we have taken and focus on some things that we can also do for future improvement. So first of all, to define our healthcare network, we are a large multi-center healthcare network provider. This is one of our sites. This is Ronald Reagan Hospital at UCLA. It's a quaternary care academic medical center, over 500 beds in multiple units. We do a number of testing here in the core lab. We also do point of care testing. We have wards like ICU, NICU, PICU, and core total laboratory automation that we have just actually implemented not too long ago. Not too far from there, we have our also Santa Monica Hospital. This is an acute care hospital with 280 beds. Similarly to Ronald Reagan, we do a large number of testing there, core laboratory, point of care as well, with multiple instruments available in many different units. We also have an outpatient testing laboratory known as the Bruin University Research Laboratory, and this is a high throughput testing site excuse me, that does a lot of testing that comes from ambulatory clinics, but also sometimes from hospitals, and they serve as backup for each other. And lastly, we have a large number of ambulatory clinics that collect samples, see patients, and they're always expanding. We have over 300 clinics now and counting. Samples are sent to the core labs, both hospital and the reference laboratory, but also there's some point of care testing that happens within each clinic and each specialty clinic. We certainly have primary care clinics, OBGYN, hemoncs, urgent care clinics, et cetera, that we also like to support. So with all that, we take a look at our laboratory industry, and this industry has consistently shown growth over the past decade at about 3 or 4% year over year. With some exceptions, for example, like during the COVID year, there was more of an increase in this laboratory revenue, and that was primarily driven by COVID testing. But nonetheless, the point that I want to make is that this is a growing industry, and as laboratorians and professionals, we're always asked to sometimes do more with less. So how do we keep up with the demand and increased testing maintaining the quality of testing that we want to maintain, and utilize resources as best as we can in an ever-growing industry that is, demands very high quality results. The other thing that I want to point out is that from my experience here, we have seen an increase in ancillary testing. So point of care testing done at the clinics, those have grown quite a bit as UCLA has expanded and added to the number of clinics. Testing not only has increased for the send out to the reference labs and core labs, but also point of care testing needs have also increased. So these are like home tests, mobile clinics, ambulatory clinics, physician office tests, and hospital ward tests, while also maintaining a steady, healthy growth in the other testing areas within the hospital sites and reference labs. So as we get into the first part of the presentation, when I want to talk a little bit about error types that occur in the laboratory and what we can do to mitigate those, I want to poll the audience and ask, in your experience, what do you think in terms of errors contributes mostly to adverse patient care? Let's give this a second. All right, we're getting a few more results here. Okay, so I think we have a pretty good distribution, almost even. A lot of focus on data entry errors, and that's certainly an area of concern, followed by invalid specimen. There can be a lot of scenarios where the specimen is invalid, and also instrument errors. So as I look at factors that contribute to laboratory testing, I think we will all agree that this divides into three sections: the pre-analytical space, analytical, and post-analytical space, with the pre-analytical space having more areas where things can go wrong and usually accounts for a greater fraction of laboratory errors that we usually encounter and have to deal with, starting from the very beginning with what the physician wants to order and actually what may get ordered. Not too long ago, we had a case in the hospital of a newborn suspected of drug abuse, drug abuse exposure from the mother, and the immunoassay screen was negative, but it only has a limited panel that it looks for. So they wanted to send it out for a broad screen by mass spec. And this is because this test is not embedded in the ordering menu. You have to request it under a different procedure as miscellaneous. So it's a little bit more lengthy, and there was a lot of delay. There was a lot of errors. The wrong specimen was ordered. The wrong test was ordered. So we had to go back and forth, and a few days passed by until we got this all sorted out. Sample collection. Well, there's a lot of things that can vary here, from using the right needle, the alcohol, how that's applied to the arm, tourniquet application, specimen collection, specimen processing, then moving that specimen to the laboratory, transportation. We can have excessive shaking that can perturb the quality of the specimen. And also things like patient preparation, whether they follow the right instruction of fasting, etc. Then there's errors that can occur in the analytical space. We have seen sometimes this is the case when the instrument slowly starts to drift. You monitor QC. We try to do our best to catch drifts, but sometimes they're not caught in time, and ultimately it leads to a retrospective analysis, and sometimes we have to amend results. Post-analytical, there can be errors in reporting, particularly affecting scenarios where the tests are not interfaced. Transcribing that result into the chart if you have to type a lot of numbers, there can be errors there and things like that. So in the pre-analytical space, we have areas where errors can occur during pre-specimen collection. So I talked about wrong tests. Patient identification can be a big one. Labeling that specimen also can be another one. If you label too early or too late, much after the specimen has been collected, that can introduce potential area for error. During specimen collection, I mentioned some of this, but just to talk about tourniquet application, needle size, anything that leads to hemolysis. Oftentimes, we're always asked about elevated potassium sometimes on the research, on the high throughput testing laboratory that appears to be normal if the patient is sent to the hospital. And there's that pre-analytical component that we suspect always is during the collection, that and patient can show up in multiple different clinics to be collected. So it's very hard to keep that protocol standardized sometimes and do the same thing and eliminate as many problems as we potentially can. Post-specimen collection. I talked about labeling. This is not the top issue, but this is an issue that still occurs. Even with the technology of barcode labeling, we still have sometimes errors within this particular space in the laboratory. And transportation, as I said, because of the tubes shaking, etc. So when we look at the proportion of pre-analytical errors, hemolysis leads up to 50%, up to 70%, if you survey the literature sometimes, is the reason for some of the pre-analytical errors is hemolysis. Then this is followed by incorrect field volume, which is important to maintain that blood to anticoagulant ratio. Other things, using the specimen, wrong specimen container, clotted sample and fibrin error, sometimes expired consumables, especially focusing on those point of care clinics that we can't always monitor as closely as we can the clinical lab, which is more close to where we are. And also patient identification, as I mentioned, if you label too early or too late after collecting that specimen, this can also be an issue. So just to dive in a little bit more on these pre-analytical issues, starting with the hemolysis. What is this? This is rupture of red blood cells and the release of red blood cell content into the space where we are conducting the testing, usually serum or plasma. And so when that happens, it can introduce error when we measure certain analytes, and we'll take a look at what. But here on the right is a schematic of what a hemolysis visual inspection used to look like before we had more automated ways of looking for this. There was a chart as laboratorians, we would match the hemolysis index and would make a call depending on the tests that were being run, whether that sample was too much hemolyzed for that particular test, or whether it was acceptable. So hemolysis can occur in vivo within the body. This is a small fraction of the samples that get affected for in vivo hemolysis. We can get a clue by looking at haptoglobin, because that will bind hemoglobin, they will be dramatically reduced. But most of the times it occurs in vitro, outside of the patient body, and this during blood collection. Sample handling, delivery can also occur during sample storage, as I mentioned. So how does hemolysis affect our variables? Spectrophotometric interference. Hemoglobin can absorb at a certain wavelength. And if we're using our instrument that uses an absorption principle for measuring other analytes that absorb at the same wavelength as hemoglobin, that can cause interference. It can release cell components into the samples, and those components that are high inside the red blood cells, when there is rupture, will contribute to the concentration of the measured analyte by increasing it. Classical examples, LDH, potassium. They are very highly concentrated in the red blood cells, and lysis, if you have a lot of it, of the red blood cells will increase those concentrations. The opposite is also true. If the analyte is much less concentrated inside red blood cells, like calcium, for example, and you have significant hemolysis, at that point we're contributing volume, so it may cause dilution or reduction in the measured analyte of interest. The other variable is lipemia. This is visible to the eye in most cases. In this picture is a dramatic example of that. The sample can be turbid and is due to chylomicrons and VLDLs. Can cause light scattering, affecting measurements of analytes. And of course, as part of the patient preparation to avoid some of this, the patients are asked to be fasting. It can cause spectrophotometric interferences, similar concept, by absorbing in a spectrum of wavelength where most other analytes would absorb that you're trying to measure, but it can also cause light scattering. And in the modern clinical chemistry now, we have a large number of assays that use turbidimetry, which principle is based on light scattering. It can also interfere that way. This can partition the sample just because you have the lipid layer on the top and the other serum layer that would be appearing usually on the bottom of that specimen. We can actually centrifuge this, and as long as it's not too severe of a lipemia case, we can remove some of that upper layer to kind of deal with some of these issues. Icterus or bilirubin in the sample can also cause preanalytical interference by absorbing that absorption spectrum, where analytes can also absorb that we're trying to measure. Unlike lipemia, this is not easily removed. This can also be harder to tell with the naked eye because the color mimics or is somewhat similar to serum, and so relying on instrumentation to detect this can be advantageous. Sometimes we deal with this. If it's not too highly elevated, try by diluting that sample and looking at those results before and after and comparing whether it's reasonable to release those results and what comment to use. So collectively, these are known as serum indices, HLA indices, and now with the modern instrumentation, we are able to take a look at those and measure whether a specimen has elevated serum indices before analyzing the analytes that are of interest to us. And the instrument will tell us if a sample is too highly lipemic or hemolyzed for the analyte that we're trying to measure. It will flag it as say that a H index or hemolysis is 100 or 200 or etc. And this is above what the allowable threshold is, and we can get all that information from the package insert or from validation studies that we may have conducted in-house. So talking about laboratory optimization, reducing errors and being able to catch them and be proactive, this has been a step forward in this space where we're actually able to use modern instrumentation to actively monitor for these type of errors and be proactive and how we want to handle them, and if releasing, how we want to release them. Challenges with these preanalytical errors, like I said, we're a busy healthcare network and we are multi-site. So having standardized protocols where patients are drawn consistently with the same needles, the same tubes, following the same procedures that spin down the tubes before sending them into the reference laboratory consistently, so they would not deal with many clot errors, is a challenging task because there are multiple options for test collection devices, needles, etc., etc. Shipping can also be a challenge. We have noticed that for some analytes, when specimens travel from the clinics into the outpatient testing laboratory, as we test the serum, sometimes they will say that it's lipemia, and it's a very low, it's slightly above the index, and we notice that those samples sometimes have a suspension in them. And upon a slight recentrifugation, that flag will go away. So transportation sometimes can affect some of the things that we do down the road and the quality of the results, and we need to be vigilant about them and how we treat those samples. Certainly not dealing with the same issues consistently, how we handle specimen mislabels, hemolysis, samples that are underfilled, overfilled, but more importantly, the process that we put forward to deal with those issues down the road. So when we were undergoing laboratory automation and a total laboratory automation, this was a big initiative for us, and it was a multi-site initiative. As I mentioned 3 sites. We have actually acquired a 4th hospital site that we are going to also be incorporating and implementing and standardizing some of our process with the new hospital system. But this provided an opportunity for us to take a look at our current workflow and our test menu and what our current challenges were and where we wanted to be further down the road. We wanted to consider things like test menu consolidation, standardizing SOPs and reference intervals, and also project for future growth that we knew was coming our ways because we had seen test volumes go up year over year in the past decade or so. So talking about laboratory consolidation, reducing errors, and allowing us time to do our job more effectively and sort of like do more with less, there are some areas that total laboratory automation had clear advantages. One of them, labor savings. So we were able to do the work that we needed to do with the increase in test volume without having to sacrifice any labors or adding FTEs. But we could repurpose that to focus on other quality improvement projects and bring more testing in-house. It led to clear enhancement in turnaround time. Also, consolidating testing. We could expand our test menu by utilizing our space better, and also middleware consolidation. So it allows us to increase our test volume, particularly at outpatient testing laboratory, where we had seen double-digit increases in test volume year over year, largely brought up by the fact that we had expanded the number of clinics that were UCLA clinics within our network that needed testing be done. Turnaround time was greatly improved. We saw across the board complete metabolic panels, TSH, standard tests that were not fully automated, but they were kind of like semi-automated, maybe required some sort of manual front loading at times to be done. Even in those, there was a significant improvement in turnaround time. And for other tests like A1C, for example, and infectious disease testing that were done still on a more standalone system that required batching, the improvement was even more dramatic. Infectious disease testing, we did receive a large number of testing at this outpatient testing laboratory. Those samples had to travel closer to the hospital sites for testing because the testing wasn't done at that site, so that added to the turnaround time. So the moment we brought that testing in addition to the hospital site, but also the outpatient testing laboratory, that turnaround time dramatically improved. Other areas, it enhanced automation based on add-on tests. Pooling a specimen was a lot more easier with automation and automated storage. Sample sorting and standout optimization. Prior to TLA, each specimen would be received in the lab, would go through a scan action process where a technologist would have to look at that specimen and determine what action needed to be taken, whether that specimen needed to be aliquoted, or centrifuged or aliquoted, sample needed to be sent out, uncapped, of course, labeling, and all those steps now can be taken by the TLA system, which helps reduce the number of manual steps. So there was also the improvement or the advantage of consolidating testing. Like I said, we removed the standalone test, optimized our space better, expanded storage as well as automated storage, and sites also served as a backup for each other. So because we had now consistent testing and lines across the 3 different sites, the results could compare a lot better, reference intervals could be much more harmonized, and sites can serve as backup for each other a lot better than not having consolidated instrumentation. And certainly our patients, they move around from a clinic to a hospital. So there's testing that get conducted in all 3 sites, even for the same patient. Middleware consolidation. So certainly this has been beneficial. Middleware is the same for all of these core testing sites now with the same vendor. And beside obvious features like receiving, processing, and storage, one advantage of that is to be able to set up rules. And so we have noticed that sometimes ISC module, and particularly on those sites where there is very large number of ISC testing being done, the sodium tends to kind of drift over time. And sometimes we're not able to catch it until a point where we see a large number of abnormal results. And at that point, we do comparisons with other lines and investigations. Unfortunately, it has led sometimes in the past to sending amended results. So being able to set rules and say, look, if sodium or analyte X concentration are now going above the reference interval, hold those results. We're going to check them on the other line, make sure we do an investigation, make sure that we're not drifting at this point, and be proactive and try to identify those errors before they actually become a significant problem and we have to send out amended results. So now moving on to the space of moving on point of care testing and some other instrumentation that we also utilize in the lab that we wouldn't be as successfully without them. I want to kind of poll the audience to this question, and this is a published case, a 40-year-old patient with elevated platelet and white blood cell count is hospitalized with serum potassium of 8, non-hemolyzed samples, and then there's a treatment that goes in place here. And then post-therapy, the concentration of potassium is still 7.5 on non-hemolyzed, and the patient becomes confused, begins to vomit, etc. The doctor now requires a whole blood potassium concentration to be measured, which yields a concentration of 2.7, and then terminates the therapy. What do you think is the most likely explanation between the two very different potassium values? Take a look at these options here. There's 4 options. Okay, I think that's a good response. So I think most of you settled on the D followed by C. So in this particular case, spinning that sample down, crushing those platelets or squeezing them released some potassium, and so therefore when they measured it in the whole blood without going through that centrifugation step, that was not the case anymore, and they were able to obtain a very different yet much more accurate result for potassium. And so this brings me to the space of blood gas testing. Blood gas instruments, these are very useful tools that if we didn't have them, we wouldn't be as successful in doing the kind of work that we do every day. And we utilize ABL 90s and ABL 800s. Difference between the two, they both do blood gas testing, metabolites, electrolytes, and hemoglobin fraction measurements, but the ABL 800 can also measure creatinine. These are instruments that are widely used in our healthcare systems, particularly in the hospital settings. We use them in our core labs, we use them in our point of care, we use them in our different clinics within the hospital systems. And just like with most types of testing, the workflow here is that There's a patient that needs to be drawn, and that patient's ID is confirmed first, sample is collected, and sample is run, and the results are transmitted into the laboratory. And there's some due diligence that goes on into making sure that the syringe sample that is drawn, is mixed, is checked for air bubbles, and ensure that that air bubble is not greater than 1/8 of an inch, etc., etc. So it's not introduced into the system. And I want to say that in this space, I mentioned the barcode labeling, and that even though this is not one of the most common pre-analytical errors, it is a area where errors do occur, and there is certainly literature that is published in this space that will talk about that. But I want to mention that there is a solution, a syringe, safe pico syringe there, that has designed a barcode that is embedded into the syringe that doesn't require the need for labeling. Yet another option to kind of automate and reduce the number of manual steps and manual labeling with some of the things that we do. This is a scenario where you would have to register that syringe next to the patient's bedside. And once it's registered, then it can travel with the patient's information. You conduct your testing, and this testing information should be in your LIS. In addition, it can do sample mixing and checks for air bubbles as well. Moving on into this point of care space now, let's take a quick result of the audience here, where your experience is that you utilize point of care testing. Because I do want to talk about some challenges and strategies within the point of care space that has led us to improving the quality of testing within our healthcare system. Okay. Very good. So most people responded that they do point of care testing in the hospital and also in the ambulatory clinics. This is our case as well. And the way that we are structured here is that we have a number of point of care tests in the hospital, and the hospital clinics are hospital-owned clinics that operate under the hospital-owned license that allows us to do waived and medium complexity testing. And then there's a number of testing that occurs within each individual ambulatory clinic where they do wave testing. Because also the size of the clinics, like I said, with over 300 clinics and growing, some of our challenge when this point of care team started to look at is that they wanted to do some consolidation and test optimization. And there was clear that there were multiple vendors with standalone systems. There was lack of standardization, that is instrumentation and procedures for instrumentation. Various different supply chains of where clinics and hospitals would get their supplies. That created service availability issue because it wasn't just one vendor now that you'd have to deal with. Some clinics may have been the isolated clinic where they use a particular vendor, where other clinics use more common vendors, etc., etc. This made it very difficult, of course, to change stuff as people move around. Sometimes you have to follow the manufacturer's instructions, and instructions from manufacturer to manufacturer may vary slightly, and doesn't help with the fact that there's a tech shortage challenge as well. So at UCLA, we have a point of care management team, and this team is involved in evaluating new test requests, validating testing, providing training, and doing an ongoing quality monitoring. This is true for the hospital-owned clinics and for the ambulatory clinics. We also have a role that we serve as consultants to those clinics because they do operate under their own licenses. So the goal was to standardize testing and test offering, standardize operation education and SOPs, and make sure that both inside the hospital and outside, we're following regulatory compliance. And on a quick look The findings were that 80% of the clinics were compliant with federal regulations, but only 20% were compliant with state regulations. And quickly after implementing the point of care team strategies, after 6 months, this was brought up, both of those targets were brought up to 100% compliant. There were things like 4 different pregnancy tests that the UCLA health clinics used, which was no need. So individual clinics even stocked different models of the same test, different urinalysis dipsticks, and urinalysis dipsticks even between vendors. When you try to read those analytes under that stick, that pad could easily have different results by like a +1 or +2, sometimes even more. Like a trace could be negative or a trace could be +1 between vendors. Sometimes even if you don't use the right procedure of reading that strip and you don't follow the timing accurately, you can have variability within the same strip and the same vendor. So area for improvement, certainly. So the decision was made to standardize and consolidate this testing through a centralized vendor and system materials management, and standardize also the inventory and allowed for bulk purchases, which allowed for better pricing. The other thing in point of care space, and as far as laboratory concerns, errors, and quality of testing is concerned, is that there's this notion, this legacy that point of care tests are not as good as clinical laboratory tests. Now, if point of care tests were not good, we wouldn't be using them, but are they not as good? It's important to know and stress that point of care testing has also evolved as laboratory testing has evolved over the years. And how good a test is, of course, it depends on design, but also it depends on things like operator competence and routine assessment of quality control. And we identified that there was little NoQC that was done on a number of these testing, and there were no dedicated timer. So clearly, if we don't perform the precision and the stuff is not as competent enough, this is not going to lead to the best results that it could potentially be used. So operator competence, standardizing those SOPs are certainly areas of paramount importance within this space, and in general with clinical laboratory space as well. So the findings and challenges in this space. So we talked about missing CLIA certificates that was corrected. We talked about training record and the fact there was a large number of instruments and vendors available, and some of this consolidation did help with standardizing SOPs, but also training for our staff. No test backups. This was another challenge. The fact that some clinics only had 1 pregnancy test instrument, for example. Well, what do you do if that instrument is no longer usable, or it goes down, or you have some issues with that instrument? The fact that there was not enough technical expertise on site or at those particular clinics to help with troubleshooting of those instruments, etc. And also, last but not least, and this kind of gets me into the next area of improvement, because I did talk about the pre-analytical, analytical errors, and also post-analytical errors, lack of middleware or interfacing into this laboratory space, and the fact that results are not interfaced but rely on manual transcribing the results. This is particularly true in the ambulatory side. We have done a good job and continue to strive forward in the hospital sites, but we haven't fully completed this yet. And so this is a survey of the ambulatory clinics at UCLA back in 2017. When this was done, they looked at 1-year period and identified that a little bit over 100,000 tests were being captured by the electronic medical record system. And it was decided this is vastly underrepresent the size of the system, of the healthcare system, They didn't even identify any monospot test in the results, but inventory was suggesting that this was actually being ordered. And we know that it's easier to document sometimes the results in the notes section. And when that is done, very hard to go back and capture those results for especially statistical purposes. System also, when this happens, it doesn't bill for point of care tests, which again is another area that we need to improve upon. Doing the enter edit field action to get some of these results in the MR is not the easiest thing. So interfacing this test then becomes quite an importance and a priority. That leads me to my next question for this audience. Are your tests interfaced? Give it another 5 seconds. Okay, that's a good participation. So most of you have all your tests either interfaced or mostly interfaced, and a few have few tests that are interfaced, and then some don't have any tests that are interfaced, and a very small proportion. It's a work in progress. So in the point of care space and the lab space, two different spaces here. In the lab space, we're particularly happy. I mean, we've standardized with one vendor that uses Infinity for interfacing this test. Testing works well. But in the point of care space, our EMR for both sides is Epic, LIS is Beaker, and then connectivity in the point of care space is RALS. And this is a middleware that it does, I would say, a fairly good job at interfacing most instrument and devices. But the challenge in this space is that we have multiple different vendors. It's not just one vendor that provides all point of care testing needs in the point of care space. You have A1C instruments that are from one vendor. You have glucose instruments that are from another vendor. You have blood gas instruments that are yet from another vendor. And so getting testing interface requires a good amount of expertise. It requires IT resources, and it requires time to get this done. And I would have to say that on the hospital side, we have made good progress. Not everything is fully interfaced, but a lot of our tests are interfaced, and we're able to monitor our program here quite well. But on the ambulatory side, this is a work in progress because they are independent clinic with their own licenses, and it's going to have to be a one clinic at a time project that we certainly intend to go ahead and start as soon as we get some resources. But when we talk about connectivity, why is this important? It's important because it helps to improve patient care and continuity and predict point of care testing needs. Like I said, if we're able to monitor the whole system and see what tests are being ordered and how much and how frequently, we can better make decisions to guide testing needs, but also instrument purchase decisions. So it can help us with that respect and as backup to justify our expenses. It can help us identify when we affected patients who have product recalls. Not too long ago, we had a notification about recall on A1C, and there were a number of lots that were affected. And so in the hospital sites, we're actually able to kind of identify and narrow it down to period and patients that could have been affected by this lot recall. But on the ambulatory side, because things are not interfaced, it's really up to individual people going and looking at paper logs and identifying whether that lot was used and when and who was affected. So it becomes a very significant job and a very significant effort. We also want to be able to have functions in our middleware to monitor the program, like QC lockout. If a QC is not done, don't perform the testing. Operator lockout. If an operator is not competent on the test or hasn't done the competency, don't allow them to perform the testing. So being able to remotely access the instrument and get information on the testing lots, calibration, maintenance of that instrument that was done, and have things for record keeping and archiving and also billing. So with that one, I'm going to have to pause and conclude here and say that, clinical laboratory testing is an ever-evolving process of optimization. And as we move along and as new technology is available and new technologies are available to us, this is a continuous improvement process as we're able to learn from, I don't want to call them errors, but some mistakes that occur and some issues that occur in the laboratory space. We're able to implement new processes and SOPs and standardization that can help to alleviate and reduce those down the road and make use of newer technology to help us do our job more effectively and efficiently as we can, and put out those quality results that we are always asked to do and we want to put out as laboratorians. And with that, I'll be happy to take any questions from this audience.
All right. Thank you very much for your presentation. And yeah, we're going to get into the Q&A portion now. So if you haven't submitted a question that you would like to ask, please do so in the Ask a Question box. And we'll try to get through as many as we have time for. The first question we have here is, will a recording of the webinar be available to the participants? I can answer that real quick. Yes, this will be on demand, and LabRoots will send out emails when it is available. First question, though, for you is, when it comes to the middleware for data and device management, what features do you hope it could do to help labs and point of care in the future? An example is AI integration to further enhance capabilities in areas.
Yeah, good question. Let me go back a couple of slides here. We want to be able to monitor our program, right? And so I mentioned the recall issue. We want to be able to identify which patients were affected by the recall in this lot of reagent, for example. Okay, so we want to be able to pull the data. We also want to be able to monitor that the QC is being run, and if a person using the instrument has not had their competency, to not be able to allow them. So these are some of the features that we want. We want to be able to pull data and analyze for laboratory stewardship efforts and see what the utilization is there. But if we could have AI jump in here, I could think of that example where I mentioned where we had the sodium values trending high because of the high usage of our instrument in this outpatient testing laboratory. Roche was saying, well, you replace the ISC every 9,000 samples or every 2 months, and if you replace it every 2 months and you're going through 9,000 samples in 1 or 2 weeks, then you really need to replace it much quicker than every 2 months because of sample utilization. So if we can have AI take a look at in real time number of injections, or let's say number of measurements, averages of analyte sodium versus, and comparing them to the different lines, line 1, 2, and 3, average is 140, line 2 is getting to 143 for sodium, number of injections is getting close to the upper limit, and then it can alert us. So we can be more proactive and utilize its features to sort of help us do the due diligence and the monitoring that we are doing, but we're doing it more manually. So obviously the labor efforts there are higher.
All right, thank you. Next one we have here is why do we have to test a venous and arterial blood gas for a newborn baby?
Sometimes I would have to, I'm not, don't have the exact answer to that, but I would say depending on what sample they can collect and what is the easiest sample of collection there.
Okay. Let's see here. If point of care testing is just as good as the testing we do in the lab, then do we need to do a better job of educating doctors that there's no need to confirm results by sending samples to the lab? Wouldn't this be unnecessary and fall under duplicate testing?
Yeah, good question. First of all, if it's as good as the lab, again, I think is that preconceived notion that point of care devices are smaller, and because they are smaller, therefore they cannot be as good as the big instruments in the lab that measure the same analytes. They are smaller. They have come a long way, but they also measure less analytes than the big instrument in the lab that measures a few dozens or even close to 100 analytes, sometimes depending on how you have it reconfigured. Yes, we can do, and I think what we can do in terms of education, we have to gain their confidence, right? So when doctors sometimes see discrepant A1C results between a point of care device and a core lab instrument, they start to lose some confidence in us, as and in the testing, for example. But I think it's important to stress out that for those point of care devices, you have to use them as they're intended. You have to have the right training. You have to follow the manufacturer's instrumentation recommendations. You have to also run QC, and this is not easily achieved because we know that so many different people use those point of care devices, and this is not your standard CLS laboratory person in the lab that specializes and is very well trained in doing patient testing. Things like a little bit too much blood into the cartridge of some of those tests or not enough blood can make the difference between a 1% variance in hemoglobin A1C results, for example. So yes, absolutely, we can do a better job at gaining the confidence of the clinicians, and I think that's where standardizing protocols, being able to monitor the whole system is of utmost importance.
All right, thank you. Next one here. What are your thoughts on the pneumatic tube transport systems for sending samples to the lab?
Yeah, I don't hear a lot of issues on the pneumatic tube. I mean, it hasn't come to my attention that we've had an issue, but I mean, it's a convenient way of transporting the sample. Obviously, you have to worry about shear stress to that sample, and hemolysis, let's also say, when the sample is transported. We can validate those systems, looking at things like hemolysis index, potassium values, lactate dehydrogenase, for example, which are known to be affected by these types of systems. We can also validate when they're coming from different locations. So yes, I think it's a convenient way of transporting the system, and there's things that we can do to make sure that quality is not impacted by those types of systems.
Got time for one or two more. Another one we have here. Are there any criteria for which types of tests are trending more towards point of care compared to the lab, such as tests that need faster turnaround?
Yeah, I think I have seen a greater demand in infectious disease testing. Um, and with that, I want to stress now that one major driver of that is the availability of some vendors and technology, again, improving and offering PCR tests or PCR tests for infectious disease testing, which are rapid, have that increased accuracy versus the traditional old antigen testing, and offer very quick times. So I think there's a great demand there. Another area that I didn't talk about is the offering availability of point of care tests to patient population that don't always have access to care. So at UCLA, we have a mobile van healthcare initiative, which is a van, has a bunch of instrumentation inside that does a number of testing like flu, COVID, they do pregnancy testing. There's also A1C there, there's hemoglobin, there's some infectious disease testing, and more coming, I think, to that. But this is a team of nurses and doctors that go out to underrepresented communities like shelters, encampments, people that don't have access to care, low-income families, and conduct testing there. So there's also this other stream of getting this type of testing to the underrepresented communities, and we have seen the impact of it and its benefits by seeing a reduction in the number of ER hospitalizations within our hospital systems.
All right. Looks like we do have time for one more. Sometimes the test results come out as equivocal. If the instrument is connected to the LIS, the result will go out directly. Do you have to repeat the test?
I would think that the middleware there would help clarify that result. If you have something in the equivocal space, I would hope that the ruling, you'd be able to set up a rule where you can repeat and clarify the test based on your SOP. Certainly SOPs, when we have tests in the equivocal space, positive, negative infectious disease testing, will have some verbiage and how many times you have to repeat it or you need to repeat it so you can clarify that equivocal result before that. I think that's how I would do it.
I think we can squeeze one more in here before we go. Do you see any particular types of testing that are more often being directed to stat labs, specialty labs, and other departments in the hospital instead of the central lab?
Yeah, so when it comes to stas testing, where I see this most, Matt, is in the space of toxicology and therapeutic drug testing. Those are tests that require fast turnaround time, like, for example, our immunosuppressants, tacrociclo, everolimus. The doctors do want those same day within, a few hours of the patient being drawn because they adjust dosing. I've also seen those requests on the toxicology space. A recent one was ethylene glycol because of they treat based on those results. These tests used to be sent out, came back after a few days. Obviously, at that point, it's good for confirmation to know if that was indeed the case based on the doctor's suspicion. But when it becomes really useful is to be able to treat based on that result. And so getting that within 1 hour, I think, has been helpful to our toxicology doctors.
All right. Well, thank you very much for your time today and your research. I'd like to thank LabRoots and our sponsor, Radiometer, for underwriting today's educational webcast. I'd also like to thank the audience for joining us today and the questions that you sent in. Any questions that we didn't have time for today or those that get submitted during the on-demand period will be addressed by the speaker via the contact information you provided when you registered. I did mention before this webcast will be available for on-demand, and LabRoots will alert you via email when it's available. We encourage you to share that email with any colleagues who might have missed the live event today. So until next time, thank you very much and goodbye.